Hello, am I audible?
Yes, sir, you're audible.
Yeah. So, good afternoon, good evening, everyone. And thank you, Arun and Jivo, for giving this opportunity to communicate with all of you. So, I am Dr. Arun Danewa. I just share my slides. My slide are visible, Varun.
Yes, sir, they are visible.
So, yeah, good afternoon once again. So, I am Dr. Arun Danewa, and I am a pediatric hematologist, oncologist, and bone marrow transplant specialist at Artemis Hospital, Gurgaon. And we are discussing today because the February celebrate as Cancer Awareness Month, and whenever the word cancer come, we think about medical oncologist. But like whenever any cardiac problem to a child, we go to pediatric cardiologist. Any neuro problem to a child, we go to the pediatric neurologist. Similarly, in India or in the Western world, now the any cancer related things now dealt by the pediatric oncologist, and it is very important because pediatric doesn't mean a tiny version of the adult, so we cannot apply the principle of treatment which applicable to the adult are also applicable to the children, and there are many reasons behind that. One reason, the biology of the cancer which happen in the pediatric age group is totally different from the adult age group. Second, the doses, the protocol are different. So, whichever disease that is common in adult and pediatric, you will see lot of difference in the treatment also. And the third and the most important, because in many time in adult, in advanced stage, we see the palliative care, or we are not much bothered about the side effect. But in pediatric age group, the child has to live for a long life, a healthy life. We just do not want to control the symptom or a 5 6 year of survival. We are seeing lifelong survival. So all these taken into the account, the principle of treatment of childhood cancer are totally different from adult, and that's why we need a pediatric oncologist. Varun, my slide are visible?
Yes, sir, they are visible, but if you can put them on full screen, like with that play button, sir, that play
Yeah,
button.
yeah, I'm trying to do that because there, yeah.
No, on the top, sir, there is a play button which is visible. Yeah, yeah, left, yeah, in between, yeah. Yes, sir. No, no,
Yeah,
right,
yeah,
with the
hide
play
behind this. Yeah.
icon. Okay.
All right. So that is the difference which I discussed between adult and pediatric. That's why we need a pediatric oncologist who deal with the pediatric problem only, so that we can give a better outcome in these conditions. So many time question arises for a general pediatrician or a physician, when we should suspect cancer. Is there any particular sign, by seeing that sign or by examining the child we can suspect cancer in the children? So answer of this question is no. The sign and the symptom of pediatric cancer or any cancer are common as the other common conditions, like prolonged fever. It can be a sign of infection, it can be a sign of any leukemia, lymphoma, or other cancer. Same time, lymph node can happen in the viral infection, lymph node can happen in the your lymphoma and leukemia also. So there is no particular sign and symptom which are separate the cancer symptoms from the general other diseases. So we have to be more vigilant. It is the persistence of the symptom more intense, and sometime combination of these symptoms, when we are not able to reaching the diagnosis, we should pick up the cancer in children. We'll see the some symptom. If I go from head to toe, cancer can happen from in the brain, it can happen in the eye, in the chest there can be lymphoma, sometimes germ cell tumor or neuroblastoma. In abdominal cavity, the adrenal gland, the tumor arises is known as the neuroblastoma. In the kidney, the tumor arises known as the Wilms tumor. In the muscle, tumor known as the rhabdomyosarcoma. In the bone, osteosarcoma and Ewing sarcoma. So symptom of these are tumor are very common symptom which can happen in other condition, but we need to be more vigilant so we can pick up them early, like early morning headache and projectile vomiting. These are some of the sign of raised ICT or brain tumor, especially early morning headache and raised ICT, and because of raised ICT, the projectile vomiting. Lymph node that is more than in the cervical lymph node which are painless. So usually painless lymph node happen in lymphomas. So lymph node which are matted or painless, they can be sign of lymphoma. Similarly, engorgement of the vein in the neck, this can be sign of mass in your mediastinum. So the veins are full because this mass compresses the venous return to the heart, and that's why you see the engrossment of the veins. Similarly, if a child with the bone tumor, so what happen in the bone tumor, the pain usually start very gradually. In the night, child is complaining there is pain, and when they are writing the pain, so slow growing pain lasting for week and weeks can be one of the sign of your bone tumor. Similarly, if leukemia is there, so your white that leukemia homing the bone marrow and it will not produce the normal cells, so the capacity to fight infection will be less. So fever again and again, bleeding spots, pallor because of the low hemoglobin, these can be sign of leukemia. And a very simple sign, when you are taking photograph of a child and there is white reflex in the eye, that is known as the white reflex, and that can be sign of retinoblastoma. So these are very subtle sign and symptom by which we can suspect, and then further by examining the child and then do the tailor-made test, we can pick up this cancer. So in the nutshell, there is no any particular sign by which we can pick up. We have to be vigilant. They are merged with the normal sign and symptom, but by vigilance and by examining that gold standard history, physical examination, your screening test, we can pick up these cancer, and then we can plan further how to diagnose them, how to stage them, and how to treat them. Now, what are the common pediatric cancer type? So, compared to the adult, if in a oncology OPD there are 100 patients sitting, pediatric age group belong only to 15 to 20 kid. So, compared to the adult, the number of pediatric cancer are less, but they do happen. And out of these pediatric cancer, leukemia is the one of the common tumor. So, if 10 patients of pediatric oncology are sitting in the OPD, 3 or 4 will belong to leukemia group. Leukemia means acute lymphoblastic leukemia, acute myeloid leukemia. These are the most common cancer in pediatric age group. Then brain tumor. Yes, the second most common tumor after leukemia and lymphoma in pediatric age group is the brain tumor. And we will discuss there are many type of brain tumor, but 3 or 4 are the most common. And after that, coming to the abdomen, the tumor which arise from the adrenal gland or the nervous system known as the neuroblastoma, which is common in pediatric age group. The second most common tumor in abdomen is Wilms tumor. This tumor arises from the kidney. So the tumor which arises from kidney is known as the Wilms tumor. Then coming to the bone cancer, there are two most common bone cancer, osteosarcoma and Ewing sarcoma. Apart from that, there are many benign bone cancer, but these are to the malignant tumor. As I discussed, tumor which arise from muscles is rhabdomyosarcoma, and we know muscle is everywhere in the body. So this rhabdomyosarcoma can happen in your orbit, it can happen in your abdominal wall, inside abdomen, or in your limb or extremity. Then the retinoblastoma, the tumor of eye is retinoblastoma. And after that, other tumor like germ cell tumor, Langer cell histiocytosis, these are the other rare tumor. So these are the spectrum of pediatric age tumor. And as you see, There is no word of lung cancer. There is no word of prostate cancer. There is no word of multiple myeloma. So these are not pediatric cancer. So that's why adult and pediatric cancer are different. So with this background, we'll little bit discuss what are the common tumor, how we treat in pediatric age group, and other important things. So coming to the most common tumor, that is leukemia. So we know the sign and symptom of leukemia is not different. Child having irritability, weight loss, fever is there. You examine and there is node in the neck, liver is enlarged, spleen is enlarged. So these are the sign of leukemia. And when you do the CBC, you can observe two things. Either your TLC is quite high in the range of 20,000, 40,000, or even in the lakhs, or sometime all the cell line are low, means your hemoglobin is low, your platelet is low, and your TLC is low. And then we need to do the bone marrow, and by doing bone marrow we can diagnose the leukemias. So the two common type leukemia are the ALL, acute lymphoblastic leukemia, and acute myeloid leukemia. Earlier, all the leukemia we diagnosed by seeing these cancer cell under the microscope, but now the science is evolved. Under the microscope, you can sometimes misdiagnose ALL as AML and AML as well ALL, and this lead to a huge difference because the treatment of both these leukemia are quite different. But now we have advanced science. We have test called flow cytometry. So this is a machine which identify acute lymphoblastic leukemia differently, acute myeloid leukemia differently. So the cancer cell on the surface, there are various marker which are different in ALN and AML. So nowadays, if anyone is diagnosing leukemia just by morphology, morphology meaning by seeing under the microscope is not correct. Flow cytometry is the requirement to diagnose your ALL or AML. And the story doesn't end here. Nowadays, every tumor is different. All ALL are not same. In some ALL, we see the response with therapy is in the tune of 90-95%, while other subgroup of ALL response is around 60 or 70. So ALL biology is also different. And to deep dive in this biology, we need next generation sequencing. What is the genetics of that tumor? And it is very important to know the genetics because it helps us in two way. One, what is the prognosis of your leukemia, and second, is there any target of this leukemia which we will target by drugs and we can get better results. So in 2026, even if you are sitting in Africa or if you're sitting in India, we need at least these three things: flow cytometry, genetic testing by NGS or PCR, and cytogenetics. And without this, we should not start the treatment. And I'll tell you, it is very important to know these things. So, how we can help? So if you diagnose any patient with ALL and if you don't have these things, you can connect Varun or Jivo and we can at least run the NGS or we can better stratify your leukemia. This ALL require this much of treatment, the standard risk treatment. This leukemia will require high risk treatment, more intensive therapy. So from the beginning, we can stratify the leukemia, the ALL and AML in better way and we can give the better result. And if we see the history, the treatment of ALL started in 1948 with small drug that is folic acid antagonist, but the survival was pathetic in the tune of 20 to 30%. Out of 10 patients, only 2 survived, 8 died because of the leukemia. But the whole scenario in last 70 years is completely changed. From 1948 to 2026, now we can say out of 10 ALL patients, we can salvage 8 or 9 patients. And this long jump in this survival happen with these chemotherapy medications. And for surprise, from 1970 to 2026, These are only 4 chemotherapy medicine which available in 1970 and which available now also. But by classifying these leukemia, which leukemia require 3 drug, which leukemia require 4 drug, which leukemia require targeted therapy, with these 4 drug only from 30-40%, now we are reached up to 90%. So it is very important to know the genetics of the leukemia, the biology of the leukemia, and the intensity of treatment that leukemia is required. So from 30%, this is marvelous. The story is now reaching up to 90%. But again, this is the Western data. So if we replicate, still we are at the tune of 80 to 85%. But in African continent, it might be low as 40 to 50%. So by joining hand, by communication, by these classes, we can also improve the survival of these 40-50% to at least 80-85%. And in some day, we also reach to the tune of 90-95%. So as I told you that there are 4 drugs: vincristine, daunorubicin, L-asparagine, and steroid. 1970 we were using these drugs. Now also we are using the same drug, but the result changed from 30-40 to 90%. One, because now we understand these leukemia in better way. The biology of leukemia we understand better way, in which we need more L-asparagine, in which we need more steroid, in which we need two daunorubicin, in which we need only 3 drugs. So by understanding the biology, and second is the supportive care. With the leukemia, the immunity is low, the chance of infection is high, but now we have good antibiotic, good supportive care, and because of combination of these things, from 30-40% to now we are sitting on 90%. Arun, it is going smoothly. Any issue?
No, sir, it's going smoothly. Please continue.
Yeah.
Sì, a parte per
So
Madonna.
the second thing is radiotherapy. When I started my training in 2010 as a MD Pediatrics, that time almost all patient of ALL get radiotherapy. And now in 2026, hardly few selected indication for the radiotherapy. So now we almost omitted the radiotherapy for ALL because of better drug, better stratification. Only those who have blast in the brain need radiotherapy. Earlier, every patient of ALL, every child of ALL used to get the brain radiotherapy, and the side effect on the growing brain was very harmful: low cognitive value, memory loss, poor school performance, and everything. But with the thanks to the science, now we reach at the stage where only very selective indication for this radiotherapy. And now moving forward in the new era of targeted therapy, now we are looking for these cell surface marker. The pathologist give us this tumor contain this cell marker, that is CD19, CD22, CD20, and we develop targeted anti-therapy. What is the benefit of these targeted therapy? They only kill the leukemia cell, while chemotherapy kill leukemia cell as well as the normal cell. But now with the advance in the science, medical science, we only target the leukemia cell, so the normal cell will not die, only the cancer cell will die, and the side effect is less. These targeted therapy, when I started my oncology training, only start evolving and use only for the relapse case, not upfront. But now there are many study which come up that we should use them as upfront, and very fantastic result. And I am very sure, if I if we discuss this in 2030, all the scenario change. The chemotherapy will go on, and upfront the tumor, the ALL will be treated with these targeted therapy only. The future is targeted therapy. Similarly, there is one subset of leukemia that is PH like ALL, and for them also we have targeted therapy, JAK inhibitor or TKI. So in the nutshell, science is evolving. We are like the precision attack. We are now moving to bombarding all the cells. Now we are just killing these cancer cell, with less side effect and more outcome. And there is, you must be heard of this new therapy, CAR T cell therapy. So science developed very innovative way. We collect the cells from patient, we engineered them, and we trained them to fight your cancer cells. So those cancer cell which targeted by our own immune system, now no drug, your own cell, bring them out, engineer them, train them, and give back. And these are chimeric antigen receptor T cells. So basically our body's immunity fighting against the cancer. And these CAR T cell and this immunotherapy or targeted therapy will be the future of the science. And one important things which India is giving to the world, we can say the cost of these therapy. Now we have 2 or 3 indigenous CAR T cell therapy available in India, which is tenth of the cost of the Western world. So we are able to, the in the Western world the CAR T cell therapy is 2 crore, 3 crore or something like that, and we are giving in the tune of 30-40 lakhs. So this will be the real boon for the medical science, for pediatric oncology, and many more trial are coming in the future, and the cost will go down and the efficacy will improve. Now the single CAR T cell therapy, now the dual CAR T cell therapy is coming. So in the nutshell, we are sitting at the tune of 80 and 90 with some side effects, some relapses. But in the future, with the help of these CAR T cell therapy, this immunotherapy, will able to succeed in that unlucky 10% of the fraction also, which relapse or which not respond to the treatment. So this is all about ALL. The second brother or of the leukemia, or the second most common leukemia, is acute myeloid leukemia. We are little bit far behind compared to the ALL. So the outcome in AML is around 50 to 60%. But again, with the improvement in the supportive care, we able to reduce the toxicity of the chemotherapy and the non-relapse death. That is, relapse happen not because of the disease, but the side effect of the treatment or of the disease itself. With the supportive care, we'll able to reduce them. Now we have good, you can say, the bone marrow transplant facility. Now we master how to do the haplo transplant. So those who relapse after the initial treatment, we able to achieve, or we able to control them with the help of bone marrow transplant. So gradually in AML also we are progressing, but not in the tune like in we saw in the ALL part, where we are reaching into 90%. In AML, I would say 60 to 70%. And again, the role of NGS is very important in AML also. We have to risk stratify which AML require only chemo, which AML require targeted therapy. So based on the genetic, we can divide them. Favorable genetics, they do well with the chemotherapy. The unfavorable genetics, we need to give chemotherapy then to see the response. And if response is okay, the response is good, continue with the chemotherapy. But if response is not good, then we have to do the bone marrow transplant in first go. So again, the role of genetic, the risk stratification, and the supportive care is very important. And with the collaboration with you, we can provide you, at least whenever a new leukemia is diagnosed, at least we can provide them, it is favorable genetics, unfavorable genetics, high risk or standard risk, and tailor made the treatment. So they can do the initial part of the treatment here, they can take protocol, they can go back to the local doctor, and they can continue the treatment, because the chemotherapy medicine is available everywhere. This is the classification, the genetics, the targetable, the to identify the target. These are the very important at the initial go. So what we can do, we can diagnose them, we can stratify them, and then they can go back with the protocol and complete the protocol in the home country. Like ALL, there are few target in AML, not that much. This drug gemtuzumab is against CD33. We have venetoclax available, the generic venetoclax available, and this is one of the target which we can use in the refractory AML, which not respond to the standard chemotherapy. Sometime if your genetics is showing particular mutation, that is FLT3, we have we have first generation, second generation, or third generation FLT3 inhibitor in the tablet form. So this will help to get into the remission the disease, or sometime after transplant to give maintenance to prevent the relapse. So these are the few things in AML, but unfortunately CAR T cell is not available in the AML, and there are multifactorial reason behind that, because AML cells lack any target antigen like ALL, the CD19, CD22, or there is antigen escape also in the AML, but maybe science evolve and in the future we'll see the CAR T cell therapy for AML also. Now coming to the third leukemia in the pediatric, that is chronic myeloid leukemia. So like this picture, this is in Atacama desert. When the rain happen in 5 to 7 years, this blooming of the flowers happen in the desert. So this is very rare event. Similarly, pediatric CML is very rare. In a year, we see 3 or 4 patients of pediatric CML. But this was the first cancer which can be treated by a pill. This is the Time magazine cover when they discover this tyrosine kinase inhibitor, this Gleevec medicine, and they announced that we have found cure for cancer, but not for all the cancer. This is particularly targeted for chronic myeloid leukemia. So no one can imagine that leukemia, the cancer, can be treated like just a pill, like a toffee. So this is the first TKI which invented in 1980, and now the progression in this field in the CML, we have second generation TKI, this is dasatinib or nilotinib, then the third generation ponatinib, and now we have the latest version asciminib. So these are the CML targeted therapy, and in the chronic phase of CML, only tablet, only OPD treatment is sufficient to control this disease. So again, this is very important to understand when we have to switch to the second generation, need to monitoring of the CML to see the response. So on the OPD basis, leukemia can be treated, and this is one of that leukemia. Now changing the gear from leukemia and lymphoma, will move to the solid tumor. As I told, brain tumor are the second most common tumor in the pediatric age group. There are 4 common type, but there are so many type in the WHO classification. There are 25 type of brain tumor, but the most common are the gliomas. Glioma can be low grade glioma or high grade glioma, medulloblastoma, ependymoma, or embryonal tumor, that is the germ cell tumor in the brain. And if commonly, if I am talking about the brain tumor, the survival is excellent. The survival in the tune of 70 to 80%, although it depend upon which type of tumor. Like a particular subset of the brain tumor, that is diffuse intrinsic pontine glioma, the survival is almost 5%. It is almost death sentence, because this tumor happen in the vital area of the brain where we cannot do the surgery. So in pediatric brain tumor, the most important role is for surgeon, the radiation oncologist, and sometime the pediatric oncologist. But when to give the chemotherapy, when to give the radiotherapy, and when to do the surgery, so this orchestra role is played by the pediatric oncologist. Like in medulloblastoma, in high risk medulloblastoma, if you give carboplatin chemotherapy with your radiotherapy, the chances of success increase by 20 to 25%. So here come the pediatric oncologist role, which decide you need chemotherapy or not with the radiotherapy, you need targeted therapy or not in this scenario. So as we discuss in leukemia part, again NGS is coming up in big way in brain tumor also. So again we are understanding how these are 25, 20, 26 type of brain tumor, how they are different. Some are just able to we are able to control with the chemotherapy or sorry, surgery or low dose chemotherapy. Some require intensive therapy. So in deep diving into this brain tumor, we identify some target in this brain tumor. Like in the glioma, there is BRAF mutation is there, MEK mutation is there. So we can, and now we have targeted therapy against BRAF. So tumor which reoccur after your chemotherapy, which are not responsive to chemotherapy, we can nicely control with these pills, dabrafenib or trametinib. Although they are expensive as of now, but in the future when the generic will come, the therapy, the cost will go down, and more or more patient can be benefit with these things. And nowadays, as I discussed, diffuse intrinsic pontine glioma, where no one, even surgeon, cannot touch that area because they are in your vital center. Here come the role of liquid biopsy. By just doing the CSF and checking the circulating DNA in CSF, we can diagnose these tumor. We can find target for these tumor. So liquid biopsy is also coming up in big way in brain tumors. So this is one of the example of my patient, huge tumor almost occupying the frontal lobe and the temporal lobe along with that. And on further testing we found with this mutation, anti-rk mutations, and we started targeted therapy against this anti-rk. And now this was the in 2022, and now we are sitting in 2026, and tumor is almost disappeared. So this is the beauty of this targeted therapy. No side effect, just patient coming just for every 3 months, checking few blood tests, and every 6 months we are doing the MRI, and he is doing well. So this is the data of glioma NGS from our center. We identify various mutations in brain tumor, and whenever they're refractory to the primary chemotherapy or surgery or recurrence of these tumor, we used to give this targeted therapy. Similarly, there are medulloblastoma is not a single disease. On the basis of genetics, there are various group, and depending upon these group, we can reduce the dose, we can increase the dose depending upon their prognosis. So this paper published in NEGM, and we can see the difference. The with the chemotherapy, only around 11% of the response, and almost 40% or 50% response with this targeted therapy. So moving forward, after brain tumor, the most common abdominal tumor is neuroblastoma. And this is the monster tumor. I call this tumor as a monster tumor. At the one spectrum, in the low risk neuroblastoma, just do the surgery, no chemotherapy, no radiation therapy, and child will be okay. But at the same time, the high risk neuroblastoma, we require all the weapon in the armamentarium like surgery, chemo, autologous BMT, radiation therapy, targeted therapy, and still the result is not that great. We are sitting in the tune of 40 to 50% of these high risk neuroblastoma. So again, identifying some targetable lesion is very important, like ALK mutation in these tumor. We can give ALK inhibitor and we can improve survival by 20 to 30% in these tumors. So these are various protocols. So there are three new therapy available for neuroblastoma. One is MIBG therapy, that is radionucleotide therapy. Another is one target on the neuroblastoma cell, that is anti-GD2 therapy, dinutuximab. And as I told, sometime 10 to 20% of neuroblastoma having this ALK mutation, and we can give them this ALK inhibitor. So we are again trying these high risk neuroblastoma where outcome is pathetic. By these targeted therapy, we trying to incorporate them, and some of these therapy are expensive, but in the future again the new molecule are coming up and the cost will go down. And below the neuroblastoma, the kidney tumor, that is known as the Wilms tumor. So how to treat Wilms tumor? So there is two approach. One is your American approach, one is your European approach. So what the American do, they do the surgery first, see the histology, the grading of the tumor, and then plan the chemotherapy. While European, they give 4 to 6 weeks of chemotherapy first, shrink the tumor, make them more accessible to the surgeon, and then do the surgery. So whichever is approach is, every approach is okay if your surgeon is confident that he can remove the tumor without spill. So it is very important. If tumor rupture happened during surgery, it will upstage the staging. So tumor rupture directly stage 3, and stage 3 require radiation therapy. So taking into consideration the pediatric surgeon is very important. If he's not confident that he can remove in toto the tumor, please give chemotherapy first, shrink the tumor, make them surgery more easable, actionable, and then do the surgery. So in Wilms tumor, chemotherapy, surgery is the important, and some subset of Wilms tumor will require radiation therapy. This is one of the my patient from Iraq. Wilms tumor was everywhere, metastatic Wilms tumor, but he's rigorously follow the protocol, the chemotherapy and radiotherapy, and this is after the 2 year after the treatment, the tumor is completely gone. So stage 4 Wilms tumor doesn't mean the end of the story. Usually in the adult we see that stage 4 means end of the story, but the story is quite different in pediatric. Stage 4 Wilms tumor, the survival is around 60 to 70%. Coming to the bone tumor, the two most common tumor is osteosarcoma and Ewing sarcoma. And just a simple examination. There are two scar, A and B. So if we see there is transverse or longitudinal scar, so which one is the right one? So this longitudinal scar is the right one, and if the surgeon for the biopsy just putting the direction of the scar, it will hamper the surgery further when we need the limb salvage surgery, because if transverse scar we need to more and more removal of the your muscles and other part in this way. So just simple measure how to put the scar for surgery makes so much of the difference. So these classes, these communication help to do in these things. So it is very important before doing the surgery, please taking into the consideration how we are putting the incision for the surgery. And for osteosarcoma and Ewing sarcoma, there is need of chemotherapy. There are various protocol for, I'm not going in the detail of this protocol. And osteosarcoma is radio resistant, so there is no role of radiation in osteosarcoma, while Ewing sarcoma there is role of radiotherapy. And very important for pediatric, many in African countries, or I'm not saying any country, but whenever you don't have expertise of these things, they do the amputation of the limb. Imagine a child whole life without a limb, how difficult for him or her to, for whole their life. So nowadays there is limb salvage surgery facility available. So if you are giving country in your home country and you don't have expertise of this limb salvage surgery, you can contact us so that we can save the leg or the hand of the child, and we can do the limb salvage surgery. And one simple measure, earlier we used to give chemotherapy every 3 weeks in Ewing sarcoma. Then they did this randomized trial and they start giving the same chemotherapy, just they reduce the duration of the chemotherapy, and there is 12 to 20% improvement in survival. With 3 week chemotherapy, survival was 65%. Just by reducing the interval between the chemotherapy, the survival reached to 73%. But more interval compressed chemotherapy require more supportive care, more fever, more febrile neutropenia. I'm not going to detail of each of the tumor. For RMS, there are various protocol depending upon the which risk group they belong. Similarly, for hepatoblastoma, some of the hepatoblastoma will require liver transplant therapy, and some of just get away with the chemotherapy and surgery alone. So in the nutshell, evidence practice is the need of the hours. Liquid tumor or solid tumor NGS coming up in the big way and helping also to find the target for the prognostications. For leukemia, we have immunotherapy and CAR T cell therapy. And I can say in India, we are delivering not exactly as the Western world, but almost the survival and the delivery is almost comparable to the Western world, and the fraction of the cost is almost 1/10 of that. And with this, I would like thank again Jiva and all the listener, and I'm happy to take any questions on this talk. Thanks.
Thanks, Dr. Arun. Thanks a lot for a very comprehensive and knowledgeable session. And we have a few comments. Dr. Ivan from Uganda commented that this One was this lecture has been amazing. Now, there's a comment from Dr. Martin Wara. Dr. Martin Wara is from Kenya. So he shares a very practical reason. The problem with most of the countries, including mine, and Dr. Martin,
Mm.
not only yours, that is true for India also. I mean, beyond big cities or big centers like Dr. Arun's, as we go to provinces and rural areas, is lack of good infrastructure for cancer treatment and the extremely high cost that is only affordable and accessible to just a very few. This
I'm
knowledge will.
agreeing with Dr. Martin also that in India we little bit far from your country, but we are also facing many problems. We need to find some local solution also with that, like generic medications coming up and improvement in the supportive care. So yes, we are also lacking, but jointly we can deliver these things in better way.
And Dr. Martin, I also have a another take on it. Like healthcare globally, like even in US, healthcare access. I think there are many factors, socio-economic factor, developmental factors, and that is something like a single hospital like Artemis or a doctor like Arun or an organization like Jivo or doctor like you cannot comprehensively change. But at least as Dr. Arun highlighted, many instances like that example that he shared that in absence of the right treatment, sometimes they do the limb amputation, which is
Yeah.
into survival also. But what we can do is at least for the ones who can afford, at least we can improve that access. You know,
But Varun,
uh,
this surgery is not very costly. Only expertise is required. So
yes,
limb salvage surgery, there is no targeted therapy like that. So it is like other orthopedic surgery. Only the implant cost is there. That is also involved in other things. So, but we have to understand every effort to make limb salvage surgery. Recently, we had one patient from I think Uganda only and underwent the limb salvage surgery and doing well. So these are just example. We have to be aware that amputation is the only last resort when the limb salvage is not possible.
okay. And another factor, Dr. Martin. I mean, as they say that. I mean, the double whammy of cancer treatment is that as long as there are surgical treatments available, that is still less costly on the pocket. But when we go to these advanced therapies, a lot of it is a lot of R&D into drugs. So the single most factor is the cost of medicines, which makes it expensive, the cancer therapies. I mean, when doctors like Dr. Arun they break down the cost, the single most factor is the cost of medicines, and that is because how medicine companies price them. Now, Dr. Martin has a question also. What are some of the risk factors for pediatric cancer, Dr. Arun? Like, if somebody have as a higher risk, like for adults, we are all aware that smoking, alcohol, etc., increase the risk. But what about kids? What are the
So
risk factors?
a nice question. So many time this is the common question whenever parents during the counseling used to ask, what is the reason why my child? So there is no particular reason behind that. We not able only 1% of the tumor which are familial or any particular genetic reason. Unfortunately, in body there are so many mutation happening, and when the body fail to check them, the immune checkpoint fail to check them, these tumor they convert to the cancerous stage. So to answer that, there is no particular reason, no viral etiology, only there are hypotheses like lung cancer is related to the your smoking or this thing. There is no particular etiological factor which we can reduce in pediatric age group, although there are hypotheses some viral etiology associated with that, but there is no pinpoint reason. Whenever we able to find these pinpoint reason, we might able to develop vaccine also. So there is no reason behind that.
Okay. Now, there's a question from Dr. Sunday, and Dr. Arun, Dr. Sunday had a specific request. He was one of the doctors who requested this topic. And also, he has asked us, then I said that when we do the master class, we'll ask the doctor. So, if you can recommend a textbook on pediatric cancers, which
So
the doctors can follow.
now in the time of AI, no one is reading textbook, but there are two textbook. One is Nathanovsky and one is Lenjowski. These I will recommend Nathanovsky is the best one. There are two part. One is for hematology and one for the solid tumor. So Nathanovsky is the book which is we used to refer for during our training time. But nowadays we have other resources like your libraries, there are Cochrane library and many other things. So that, but I can help if doctor want for any particular pediatric tumor, I can share. I have so many presentations I used to share with them. If they want, I will share the protocol or my presentation happily.
That will be great, Dr. Arun. We will represent it like as if the protocol by Dr. Arun, and we will also in the coming week we will also share the transcript and based on Dr. Arun's lecture, whatever are the scientific, the medical aspects, we'll share that smaller document also.
Yeah.
Now, there's another question from Dr. Sunday. His question is targeted therapy readily available, and what is the cost?
So it depend upon for which disease we are talking. If I am talking about the ALL, both the targeted therapy, there are two major targeted therapy, inotuzumab and blinatumomab. Both of targeted therapy is available. Inotuzumab is cheaper because it require only daycare admission. Blinatumomab is costlier. For Indians also it is costlier, and it required 28 days of hospitalization and continuous infusion of the drug. So that is little bit difficult, but thankfully there are few center which on humanitarian ground they are provided free of cost in India. This blinatumomab, inotuzumab is easily available, and there are support scheme also. Suppose like if you buy one vial, the other vial will be free. So these are the few things in the ALL, the two targeted therapy. In the brain tumor, both the targeted therapy is available, and again there is some patient assistance program also available in that thing. Coming to the neuroblastoma, dinutuximab is a costlier treatment. It will cost around 70 to 80 lakh Indian rupees. Now the cost is down because of some changes in their policies. So yes, targeted therapy is available, which are standard of care, FDA approved. It is available, or we can import them. But the only thing is the cost. Some are affordable, I would say, and some are little bit expensive.
Dr. Arun, like I know it's very difficult to pinpoint, but just for a ballpark figure or a range, because as we know, we assist so many patients, and like empirical evidence says that surgical options are more affordable the moment we
Mhm.
move it to cancer drugs. The palliative care, it starts getting costly because first we have to determine the right therapy. But still,
Mhm.
let's say because many times doctors have to counsel the families, and this is the first question they encounter. Although they cannot give an exact answer, but what range is like these targeted therapies, different diseases in US dollars, like you said, the expensive
So,
range
uh,
70, 80 lakhs would be like
yeah. So
80,000 US dollars.
I will talk the, as we discuss, ALL is the most common cancer and the mostly required the targeted therapy when relapse happen. Now every relapse protocol has this targeted therapy, inotuzumab or blinatumomab. For inotuzumab, one cycle, if in the US dollar, if I'm talking about, it will cost around 10,000 to 12,000 US dollar for one cycle. That one cycle is usually day 1, day 8 and day 15. So 12 to 15,000 US dollar will cost for this targeted therapy. The blinatumomab is costly. It will be cost you around 30 to 40 lakh Indian rupees. So it is costly. So that's why we hardly offer blinatumomab for any international patient. But inotuzumab we are using very commonly, very, very commonly. Similarly, in Hodgkin lymphoma, there is brentuximab and nivolumab, that is immunotherapy, which will cost you around 12,000 to 15,000, again in the same range. So these are the, in lymphoma and leukemia, these targeted therapy are, I would say, affordable. The blinatumomab, the dinutuximab are very, very costly, and we hardly use them once in a while in a year or so that.
Okay. So now there's a request from Dr. Ivan from Uganda. He says that can you talk briefly about, I know it's another topic, stem cell transplant, but just briefly touch upon it,
Yeah.
the stem cell transplant in the management.
So again, stem cell transplant, the success and the indication differ from the disease to disease. If I'm talking in the pediatric leukemia, there is no role of upfront bone marrow transplant, only selected indication when your there is no morphological remission. What is the meaning of morphological remission? When your blast is more than 10% at the end of the first month, that is your failure of the morphological remission, or selected subset where your chromosome number is less than 44, that is hypodiploidy. Apart from this, whenever leukemia reoccur, most of them require bone marrow transplant. For benign condition for African continent, the most common indication is sickle cell anemia. Sickle cell anemia, a disease, a lifelong debilitating disease where the transplant is required. Gene therapy is also coming up big way, but it will take time. So the sickle cell anemia is another condition. But I want to add one thing. Earlier the transplant, better is the result. So in the sickle cell, I am happy to do the transplant below 12 year of age. After 12 year of age, I would little bit hesitate and the success rate will go down, the complication will go up. So one message through all of you I want to convey: if any sickle patient, transplant indicated, what are the indication for transplant in sickle? If you have recurrent pain crisis, two or more than two pain crisis in a year, any stroke, any your chest syndrome, these are the few indication where sickle require transplant. So whenever any candidate for transplant in sickle, do transplant in early age, so we will give better result. The bone marrow transplant is three type. When you have full match brother or sister is available, that is the sibling or match sibling donor transplant. When you don't have full match in your family, but there are registry which provide you the full match, if you are lucky one, so that is match unrelated donor transplant. And the last is the half match transplant from mother or father, haploidentical transplant. In same hierarchy, the outcome is there, the best outcome in the match sibling, little bit lower in the match unrelated donor. And as a general, if I am talking haplo transplant, the success rate is around 70 to 80%, but it vary from disease to disease.
Okay. So now we have a few questions from, okay, first a compliment from Dr. Kenari Davis. Thank you for the comprehensive talk on cancers. I think we have a lot to learn from you and need your input in care of your patients here in Kenya. Thanks, Dr. Davis, for raising this point. As you must have noticed that for the month of March, we have planned several Connect Clinical drive that aims to do the same, like plug your clinic with at agreed upon schedule with the Indian specialist, so that together the African doctor and the Indian doctor can help the patient and give them better clarity, and they can plan what assistance can be given, what treatment path can be followed, and everything can be worked out. So
Agreed with the
we,
Varun.
we
So this should not be one time job.
this should be
Communication,
regular. No,
follow
I had
up,
yesterday I
discussion,
had
utmost important. I'm agreed on that. So one class, one time discussion is not sufficient for these things. So we should, Varun is here to help us. So create group whenever query, patient is coming or not coming, they are sitting there. Whatever knowledge or expertise I have, I am happy to share with you, and so that patient can get benefit from that.
No, so Dr. Arun, what we are doing is, because uh, we have to expand clinical settings also. Masterclass in knowledge sharing. So
Yeah.
what we have to, in this day and age of technology, what we have done is we have launched this connect clinics. So we agree on a schedule and a specialist, and doctors can align relevant patients,
All
and the
right.
patient gets a joint consultation.
Yes.
It's
Nice.
like augmenting, like let's say if Dr. Canary Davis organizes it, let's say for childhood cancers, his clinic or
Mhm.
his hospital is augmented by Artemis capability and your capability
Nice.
for
So
that
yeah.
day and for that schedule, and we can make it regular because
Yes.
technology is way of the future, and this doctor collaboration on both sides is the right solution rather than doing marketing or just those what agents do, just sending patients
Yeah.
to India. So this is what we
This
are
is very
planning,
this this
Dr.
this is very important. So any patient treated by me, if again going to Dr. Kanari or some other doctor, I am happy to again discuss with them.
Okay. So, now Dr. Canary Davis has a question. Other than cancers for disorders like sickle cell disease, do you offer bone marrow? Yes, the doctor, I think this was discovered.
Uh-huh.
Yes, Dr. Davis, they offer. It's very common and have lost even
Yeah.
fellow doctors and many friends to it all in their 20s. Is there a cure? Yes, bone marrow transplant is a cure. Dr. Arun briefly covered it. One of his colleagues and some of the leaders in bone marrow transplant, Dr. Dharma, has talked about this in detail. We'll share the copies of the lectures and transcripts. But as Dr. Arun highlighted, the earlier it is done, the better,
Yes.
because as Dr. Dharma discussed, there is no strict age cutoff. But the reason age is
Okay.
correlated is because the longer they wait, the more damage happens, comorbidity develops, and hence the success
Agreed.
rate. So the earlier they identified, the earlier treatment is offered, the better chance. And India, I mean, hospitals like Artemis and others, because Artemis Masterclass, so let's talk about Artemis. So the skill is very good, as Dr. Arun said, in this bone marrow transplant. It's at par with US at their best centers, the best centers of US or UK, and the cost is 10% of them. So, Dr. Davis, happy to assist you with more information material, and happy to talk to you, discuss if you have any, and we can organize a connect clinic drive specifically for this, like hematology cancers or this sickle cell. We can discuss a schedule with doctors like Dr. Arun and come up with a connect clinic drive for the month of April.
Sure.
So now we have a question from Darius Mulumba. Dr. Darius Mulumba is from DRC. He's a French speaker. But thank you very much for the presentation. We encourage you to always update our knowledge related profession, which is a noble job. Please also with the French national. Yeah, Dr. Darius, as you have noticed that since the past few weeks, we have started sharing, thanks to AI, our, our job has become simpler.
Yes.
Zoom gives us a raw transcript. AI helps us with minimal errors in a clean transcript, and also it helps us in accurate French translation. And we will share the structured summary, structured transcript, also a summary, and also based on what Dr. Arun has discussed, because he discussed many protocols and guidelines, a ready reference so that you can refer to it in your practice, and whenever there's anything, you can come back to us. Uh, there's a question from Dr. There's a comment from Dr. Amma David. He's from Nigeria. Thank you for the lecture. It was all encompassing. Now, again, Dr. Ivan Ipavu wants to ask about CAR T cell therapy. How effective is it? Dr. Ivan Ipavu, first, we conducted a master class on it. We will share the recording with you. But second, Dr. Arun touched upon it. In ALL, it is very effective. In AML, not yet. But Dr.
Yeah.
Arun, if you touch upon it again, that will be
So,
better.
in Western world, or there is data now, the long term data is coming up, the CAR T cell therapy. Earlier it was only in the naive data, and the data is around 50 to 60% success. And the same with the indigenous CAR T cell therapy. We are new in this field, our indigenous CAR T cell therapy new in this field, but this 4 5 year data is showing almost similar 50 to 60% chance. So earlier the relapse refractory, where is no therapy is effective, the chances are 5 to 10%. From 5 to 10%, we are now heading toward 50%, I would say, in general.
So, Dr. Arun, for laymen's like us, like CAR T cell sounds like a big word, a big
Yeah.
like fad. So compared to how traditional therapies have evolved, chemo, immuno, targeted. So where does CAR T cell therapy sit in there? Like
So,
it is tailored to the genetic makeup of the
mm,
tumor, or what
no,
happens?
so basically they identify target on the cancer cells. Like one target on the cancer cell in ALL is CD19. So they are targeting this CD19. So CAR T cell, this CD19 happen only in the cancer cell, not in the normal cells. So they will go and kill this CD19 cell, that is the blast. Similarly, CD22 is there, and now they combine both CD19 and CD22. So these are the surface antigen on the cancer cell against which we trained our T cell go and fight them. So so that is the, or like, why I am cancer free, because my immune system is checking all the mutations whatever happening. My T cell inside my body is checking that whenever this mechanism fell, cancer happen. This checking mechanism. So what we are in the CAR T cells therapy, we bring the cells, we again teach them go and fight this cancer. So that is the CAR T cell therapy, and it is coming in big way. Recently I attended one of the meeting of cellular therapy in Bengaluru. This was the third meeting, and it was very exciting. There are around 20 to 25 indigenous CAR T cell therapies coming in next 3 4 years, and they are in the early pipeline, early trial phase. So soon the cost will go down. With the dual CAR therapy, the efficacy will go up. So cancer cell are smart. We target them with the CD19 target. They come up with the CD22, the escape mechanism. So to overcome this mechanism, now we are using dual CAR T cell therapy. If you escape from CD19, we'll throw them CD22 or together. So this the way of CAR T cell therapy. In solid tumor CAR T cell therapy is coming, like neuroblastoma I touched upon. There is anti-GD2 CAR T cell therapy is coming up. For brain tumor CAR T cell therapy is coming up. So CAR T cell therapy will be the future. although this is not the alone holy grail, as I said, that we are sitting still 40 to 50% long way to go, but at least from nothing to 40 to 50%.
But Dr. Arun, like these days, when the pace of development in drugs and data modeling, thanks to AI, it is going very fast. So, like you discussed, you shared one thing, that earlier you shared a long timeline that
Yes,
ALL 20% success, 10 to 20% success to now 80% success. That
yes,
timeline was very long. But I think
yeah.
with technological advancements in all aspects, I think this CAR T-cell therapy from 40 to 50% to
Yes,
80%
it is. It
will
is.
be
It is
far
moving.
shorter, right?
Yes, agreed with you, Varun. It is moving very fast. Like technology, earlier there was no AI, and now we are seeing boom in the AI. Similarly, in the medical science, these things are developing so quickly. So future is good with these innovation.
Okay. Thank you, Dr. Arun, and thanks a lot. Thanks everybody who joined us today
Yeah.
and asked
Thank
questions
you,
and
everyone.
made the
Yeah.
session so interactive. I enjoyed the interaction a lot. I hope Dr. Arun also
Yeah, yeah, same here.
enjoyed.
I'm always happy to share knowledge and listen or whatever I have to share the things. We can do these classes in future whenever required. I'm happy to do that.
Okay. So, I wanted to take 2 minutes of everybody's time before I give a vote of thanks to Dr. Arun. So, as I shared in the beginning, and as many doctors keep touching on, whatever we do in healthcare, it's at the end of the day, it's benefiting patients. To the extent we can. And at Jivo, as you've all seen, we fundamentally believe healthcare requires participation of healthcare professionals, doctors everywhere. And Masterclass was one way of aligning the or activating the Africa to India axis. The second is the doctors actually benefiting, or Jivo doctors actually benefiting from the Indian doctors' expertise. For this, we have launched Jivo Connect Clinic initiative. For the March, the schedule has already been shared with you. The first step, as we call, is spreading awareness. If your community or your patients are not aware that an Indian doctor can join your clinic and give specialist opinion, then people will not approach you for help. So my request is that you spread awareness, and we help as many patients as possible through this. A good response will motivate us and our Indian hospital partners and the doctors participating, and this can become a regular feature. And this one single act can change how healthcare is delivered globally and in cross-border setting. As Dr. Arun also in his lecture specified that the real need to come to India is for that comprehensive investigation, determining the right therapy, the rest based on the protocol, medicine, etc., that can continue for the long term under the care of local African doctors and oncologists. So my request is that we participate in this drive proactively and make it a success so that this can become a regular feature. And this Jivo Connect Clinic feature, like I will sound cliched, but as we know from the moon landing, they said that this is a small step for us, but a giant leap for humankind. If African clinicians and hospitals, OPDs are plugged with Indian specialty, far more patients will benefit compared to the traditional what how medical tourism works now. So thank you all for attending, and thanks a lot.
Thank
Thank
you,
you,
everyone.
Dr.
Thank you.
Arun. I
Thank you,
mean,
Varun.
if
Thank
if
you.
a layman like me could follow what you were discussing, I'm sure our doctor colleagues had a lot to learn, and it will give them clarity how to approach such cases. And thanks a lot. Thanks a
Thank
lot.
you. Thank you, everyone.
Yeah.
Thank you.
Thank you. Thank you. Thank you.